Well, hello, everyone. Good afternoon and good evening, and maybe even good morning, depending on where you are joining us from. I'm Kimara Ellefson, and I am fortunate enough to serve as the National Director of Strategy and Partnerships for the Kern National Network for Flourishing in Medicine, or the KNN. And I am pleased to welcome you to the second session in our series, Foundations for Flourishing, Creating Caring Systems. And it seems to me that this topic, while always important, is front of mind and so vital for our systems and for the world in which we are part, particularly at this time. For those of you that are not familiar with the KNN, we are a national movement focused on integrating 4 foundational elements within the profession of medicine: character, caring, and practical wisdom towards flourishing. And to do so, we seek to connect, convene, and catalyze efforts to influence the culture within the field of medicine. By coming together and openly exchanging ideas and learning from one another, we can move forward with greater momentum in creating healthcare environments where all those within can truly flourish. So considering that mission and the series title, Foundations for Flourishing, it's worth considering why flourishing and what does that mean? Well, the KNN defines flourishing as a wholeness of being and doing, of realizing one's own potential and helping others to do the same. And although efforts focused on wellness and well-being are important and necessary, we believe that the holistic approach and the relational aspect of flourishing, the fact that it's so deeply rooted in community, is part of what differentiates flourishing and why we focus on that as our hopeful and aspirational outcome. It's also what makes flourishing so appropriate as the North Star for our work, the overarching aim of medical education and practice. Recognizing that flourishing is dynamic and not something that is static or a destination at which we arrive, we intentionally lean into the organic imagery of the tree with its leaves and its changing colors, which, depending on where you live in the world, we are seeing in all of its brilliance right now. The branches show how the interrelated elements of character, caring, and practical wisdom work together to lead towards flourishing, and the blue concentric rings show our ecological approach, recognizing that these concepts operate at multiple levels, from individual to organizational to societal. And that's certainly the case for caring, which is our focus today, which aims to ensure that individuals and populations grow, develop, and flourish as best they can, creating a stronger society and democracy. Next slide, please. As we'll hear in today's session, caring requires that we lean into community and into complexity, navigating difficult scenarios and ethical questions that come our way within these incredibly complex institutions that we're all a part, as well as within our broader society and our democracy. That complexity makes it essential to recognize the many different perspectives that are involved in any given situation. It highlights the importance of seeking to understand, of entering into another's experiences, and meeting people where they are along the way. So, my hope is that as we enter this discussion today, that we will enter with that same spirit of curiosity, of open inquiry, of exploring different ideas, perspectives, even potential areas of disagreement, with caring, with character, and with integrity. Today, we are honored to have 2 incredible thinkers and speakers with us. You are in for quite a treat. We are going to begin this evening with Dr. Joan Tronto, who's Professor Emerita from the University of Minnesota and City University of New York. Joan is the author of many works on care ethics, including over 50 articles and several books, such as Moral Boundaries, A Political Argument for an Ethics of Care, as well as Caring Democracy, Markets, Equality, and Justice. In fact, I am staring at both of these works on my bookshelf, as these are seminal works that have helped inform the KNN's definition of caring. And we are so honored to have Dr. Tronto with us this evening. So thank you. We're going to start. We also have Dr. Sonia N, Dean of Educational Affairs for Geisel School of Medicine at Dartmouth. She leads the school's educational programs with oversight of the medical education and health professions education programs and all student life shared services. Dr. Chimienti contributed to the development of the KNN's framework during our first phase of the work, and she brings deep experience with integrating its elements into academic medicine. We're so excited to hear from both of you today and your different perspectives on caring and its place in our democracy. After the presentations today, we will take questions, so feel free to submit those questions in chat as they come to mind, and we'll queue those up for a question and answer session. So to start off this evening, Dr. Tronto is going to unpack what it means to elevate an ethic of care, and she's going to explore elements such as relationships, responsibility, and purpose that come into play. Joan, welcome. We're so grateful to have you.
Hi, everyone. I'm really delighted to be here tonight. I have been speaking with the members of the KNN leadership for some time, and I'm really delighted that they've made care a centerpiece of how we need to think about educating doctors and how we need to think about the practices of medicine. Because there's really a revolution going on in the world, I think, really a revolution that will make it possible for all of us to think differently about the world, and that is to put care, rather than economic life or political power, at the center of all that we do. So what I want to do today is really, full disclosure, I'm not a medical doctor, I'm a political theorist. And my understanding of care largely comes from thinking about care in terms of power imbalances and responsibilities. So that's where I'm going to start, and that's pretty much what I'm going to focus on. So let's go to the first slide. How can care change our perceptions of medicine? What I'd like to do is begin by talking about an opening vignette. This is from an article in the New York Times late last month. As you probably know, the mortality rate for infants and mothers who are African Americans is much higher than it is for other ethnic groups in the US, and much higher in the United States than everywhere else in the developed world. One of the things that seems to help is when women who are African American find themselves in supportive settings like a midwife center, which is run by people of color, they do better. The outcomes are better. But in Alabama, the Department of Public Health is trying to close the birth centers in the state and has issued a set of rulings which make it impossible for them to obtain licenses to practice. Although Alabama has one of the worst infant and mother's mortality rates in the US, one of the requirements is that there's a nearby hospital. But of course, much of Alabama is a health desert. Almost 2/3 of the counties in Alabama have little or no local maternity care options. As a result, to make this requirement is basically to say that you're going to close down these centers. Now, the question I want to start with is this a concern for doctors? Or is this simply a matter of public health? Next slide. When we talk about care, I have continued to use the definition that my colleague Berenice Fisher and I came up with all the way back in 1990. We argued that on the most general level, we suggest that caring be viewed as a species activity that includes everything that we do to maintain, continue, and repair our world so that we can live in it as well as possible. That world includes our bodies, ourselves, and our environment, all of which we seek to interweave in a complex, life-sustaining web. Now, you can tell I'm a political theorist and not a philosopher, because a philosopher would be embarrassed by this definition, and philosophers hate it. They say, Joan, that definition is so broad. What counts as caring then? And I say, well, a lot. Almost everything counts as caring on some level. Everything we do to maintain, continue, and repair our world so that we can live in it as well as possible. And what's the standard so that we can live in the world as well as possible? Well, that's not much of a standard. It varies. Yes, it does. And it means that we are constantly responsible for making sure that we know what we mean when we say we're living as well as possible. Notice that this definition is on the most general level. There are other practices, of course, which are embedded in care on this general level. And within those individual practices, we can be much more specific about what constitutes good care. A phlebotomist has to have an understanding of that practice in order to care well in that way. But on the general level, this is what we can think about. Next slide. Berenice and I also made it slightly more concrete by offering some phases of care that make it clear what caring is about. We argued that there were 4 phases of care. I've since added a 5th. The first is caring about. It requires that we see needs for care in the first place. And to me, this means that there's a moral quality of caring, which is that we have to be attentive to problems and needs. Second, caring for. Here, we have to actually assume responsibility for the problem. I'll give you an example. Here in New York City, where I live, there are a lot of homeless people on the street. Some people don't even see them. They don't care enough even to be attentive to the fact that they're there. But if you walk past a homeless person and say, somebody should do something about that, that person smells, you haven't assumed responsibility. You've simply passed it on to someone else. And this requires the moral quality, of course, then, of being responsible and saying, we have to do something about this. Caregiving is the actual hands-on doing of care work, and it requires the moral quality of competence. We don't usually think of competence as a moral quality. We usually think of it as a technical quality. But to be incompetent in trying to do your caring is actually a moral failing as well as a failing of competence. Fourth, care receiving. Once the care has happened, there has to be some response to that given care. Does the patient get better? Are they responding to this treatment? Does the Alzheimer's patient smile back at you? All of these require the moral quality of responsiveness. And both the person receiving the care and the person giving care and all those around have to be responsive to see what's actually happening. When I started to think of this more politically, I also became clear to me that we need a category called caring with. This is what happens when we repeat care over time, and then we can come to rely on that care being there. The repetition of the care becomes reliable and dependable, and it creates or requires the moral qualities of trust and solidarity. So that gives us a more concrete way of thinking about what constitutes care. Now, is care the same thing as a feature of character? Well, it's certainly the case that we can think of care as a feature of good character, and my former PhD student, Stephen Stale, has written about care as a virtue, which makes it a characteristic of good character. But for me, what makes care ethics valuable is not only that it's a part of character, which focuses on individuals, but that it is broadly different as an approach that is relational rather than a static ethic. And responsibility is the key concern. So let me talk about what constitutes a relational approach. So next slide. This is actually adopted from Margaret Walker's understanding in moral understandings of 2 different kinds of morality, but I'll call them here by different names. So a static or substantive ethics argues that individuals who are possessed of good character and knowledge should and do have more power as a result of this goodness. A social contract emerges that regulates interactions and stresses the autonomy of individuals and their prior rights. And justice under this kind of ethics consists of limiting abuses that become rarer through enhancing and correcting individuals' character, power, and knowledge, and distributing goods among deserving individuals. So to me, that kind of substantive ethics is the one that we usually work with in our society. We think of ethics as kind of Walker's language, a theoretical, juridical language in which we figure out what the principle is, and then we apply it to the individual case. And we'll know when we've got the right answer because it fits with all of the ways that we have previously thought about these questions. A relational ethics is different. A relational ethics starts from the view that we are all, to use language, Walker's language of moral understandings, we're all kind of muddling through. After all, what counts as moral changes over time. And we know this is true. Think of the different ways in which we think about homosexuality or race compared to 100 years ago when it was perfectly acceptable to be racist in this culture. And now most people would say, no, it is not. So ideas of morality do change over time. And so in any given moment, any given society has a set of moral understandings which it uses. Individuals, communities, and even other objects are in a constant state of interaction and interdependent effects on one another. And what makes the ethic work is that in looking at these different relationships, we figure out what's going to work and work well for everyone. When people begin to demand rights or say, you can't treat me without dignity, that is invoking a different kind of relationship than has existed before, and it requires an ethical response. So I argued in Caring Democracy that morality consists of compromises and judgments within a community that yield evolving moral understandings. Power is woven throughout, and justice consists of more inclusion and better judgments. We have to think about who should exercise power, about what, when, where, how, and why. And we need to think about, now to bring it back to caring, we need to think about who cares for whom, what, why, and how. We can go to the next slide. So how does care understood relationally help us to address ethical questions in complex institutions and society? In an essay that I published back in 2010, I hit on 3 themes which I think really help us to understand how care operates within organizations. And that is, all organizations have power within them flowing, all organizations have purposiveness or the lack thereof, and all organizations can be more or less pluralistic. The ethic of care understood relationally sees problems, that is, needs that need to be fixed. Care is not a commodity. I'm sorry, I should restate this point. The bullet isn't really clear. We can see the problems in an organization when we see these kinds of things crop up. We see people perceive needs as fixed rather than changeable and negotiable, and rather than coming from the people who are being cared for themselves. When the doctors in Alabama say to the public health officials, you know, I'm not sure midwives really know what they're doing, having not consulted midwives or the women who are treated and have had children both in the regular hospital system and with the midwives, they're seeing the needs as fixed and as if they can define them, and that's a problem. Second, if you see care as a commodity, as something which can simply be distributed, if we give everyone enough COVID tests, then we'll make sure that everybody knows what's going on. That too is to see care in a wrong way. If we are inadequately attentive, we see that there's a problem in the organization. And when we don't include those with needs in making the judgments, we are developing a kind of problem within organizations that often happens. And finally, in the absence of pluralism, in the absence of many different voices, many different approaches, many different kinds of people, we're likely to be in an organization that's not really very caring. So the article specifies ways to recognize badly performing institutions. That's what that list did, but it didn't really explain what to do about them. So let me go on now and see if I can address that question more directly. The responsibility, obviously, to me, is going to, the key is obviously going to be responsibility. Obligation is a static term, and people sometimes think that responsibility and obligation are the same idea, but they're not. An obligation is static. It's fixed because we've made a contract and therefore I know what my obligations are. But responsibility is necessarily relational and it will change over time or through the interaction of that relationship. The word responsibility itself grows out of response, and so it is always interactive and subject to change. What constitutes a proper form of responsibility then requires these two words are Margaret Walker's, an ongoing negotiation of what we're thinking is the proper kind of relationship for us to have and how we should be responsible within it. We can go to the next slide. Walker puts the point this way. We are not all responsible for the same things in the same ways, at the same costs, or with similar exposure to demand or blame by the same judges. So we might ask the question, do doctors hold most of the responsibility in medical care? And should they? Well, sometimes it would be right to think that, yes, doctors are the most responsible parties. But it is also the case that we sometimes need to think about the ways in which taking responsibility from others is a kind of harm to them. Walker writes it this way. Sometimes it is a privilege or a mercy to be exempted from responsibilities. Sometimes it shows you're a nobody or less of a somebody than somebody else. Assignments of responsibility are a form of moral address, but some are addressed as peers, others as superiors or subordinates. Care ethics asks us to focus on responsibility, which then suggests that these are problems which really come up. The problem of complexity, the problem of hierarchy, and unclear lines of responsibility. So let me talk about those three ideas for a moment. First, complexity. Even if doctors are the most important actors in systems of healthcare, we also know that healthcare systems often displace the opinions of doctors or the positions of doctors or the decisions of doctors. And this is becoming increasingly a problem. Here's a quotation from an article from more than 20 years ago. Doctors may still be the most important actors, but in their capacity as doctors, they no longer direct the play. And that article went on, as care becomes more complex and fractured, so the opportunities for errors of commission and omission have risen. Now, this is, to me, a question of allocating responsibility. And it means that those in the hospital have to think about ways to make it possible to allocate responsibility effectively. Next slide. Let's talk for a moment about purpose. In a fragmented system where it's not clear who's making the final decision, dispersed power makes it more difficult for actors to focus on the purposes of the institution. After all, this is an interesting thing about institutions. Institutions also have a logic of their own. And sometimes instead of paying attention to the institution of the purpose of the institution as a whole, we begin to pay attention to our own place within the institution. How do I get to be the director of the so-and-so rather than what's better for the institution as a whole? So given the complexity of competing purposes in healthcare, whose version of purpose wins out becomes an important issue. The next question, the next slide. And finally, I want to suggest to you that one of the problems that may occur a lot in medicine is hierarchy. Doctors have received extraordinary educations, and they know an awful lot about human medicine. But one of the problems is that an effective hierarchy is always to make more difficult for information to flow up. And this is true in all kinds of institutions. In a survey about doctors and nurses that was done some years ago, they discovered that the doctors thought lines of communication were fully open, and the nurses thought that the doctors didn't listen to them at all. So this becomes a question of responsibility. Whose task is it to ensure that information is fully available and fully used? And as you know, in the last decade or so, there's been a move to use checklists, which, among other things, empower everyone in a medical situation to call out when they think some item on the list has not been properly taken care of. Next slide. But sometimes being in a position of power allows you to simply set your responsibility aside. And this happens everywhere in our culture. Sometimes we simply refuse to take responsibility. Sometimes we simply refuse to see that something might be partly our responsibility. To me, this is a chief reason why making care democratic is always better, because it means that those on the bottom have their voices heard. And it means that those who might overlook an issue of responsibility because they haven't really thought about that fact before might not work out, might now be able to work out what it is that's missing in their situation. One last complication here is what Phil Pettit called in an article he published a long time ago, Responsibility Inc. And in Responsibility Inc., he talks about the Exxon Valdez oil spill and asks the question, who was responsible? It was hard even to figure out who owned the ship that ran aground, because complex organizations often disguise lines of responsibility for their own purposes. If you don't know who's responsible, then you can't receive the blame. And as a way of pointing blame constantly to someone else, sometimes complex organizations simply hide responsibility. And this is a really serious problem when it begins to operate within medicine. Next slide. Here's another example of the way that responsibility can be, in this case, outsourced. Increasingly, organizations, it seems to me, seem to push greater levels and forms of responsibility down onto the direct workers without providing them with the resources to achieve these ends. Let me give you two examples. In Belgium, nursing students who quit after their first rotation in the hospital were simply giving up. And they gave up because they were inadequately trained, because the people in the hospital were so overworked that they didn't have time to give them adequate training. And so when they got to the hospital, they were either assigned menial tasks, which made them feel, why did I become a nurse if what I'm going to do is change bedpans? Or they were told, go put an IV in that patient, when they really didn't have any experience doing that. And they were really afraid that they would harm their patients. And so a lot of these students were just quitting, and it pointed to a problem that needed to be addressed. Sorry. Another example of this is Adia Harvey Wingfield's remarkable book, you should read it, called Flatlining: Race, Work, and Healthcare in the New Economy. She talked about the fact that medical professionals of color bear the burden of furthering diversity in their institutions. She called this racial outsourcing. Let's go on to the next slide. So to conclude, let me make some concrete suggestions and raise some questions. Doctors continue to enjoy enormous public support and trust. As trust has eroded in every other kind of institution, doctors continue to have it. And I hope doctors will both appreciate what a responsibility that is and will use their trust appropriately. Second, evaluating organizations requires us to return constantly to the issues of purpose, power, and pluralism, and to see how allocating responsibility is working in an institution. We can think about this question. If you're in an institution where things are not going well, who can be your allies? Who, other than doctors, can raise these issues? How can doctors learn to identify these problems and address them themselves? patients come with a context, fourthly, that you do and do not know, which requires that you be attentive, which takes time, which I know is something that is in short supply always in care settings. Margaret Walker 5 talked about ethical hotspots arise when power is engaged, and the relationship between patient and doctor is always then an ethical hotspot. But the most important thing perhaps you can do, 6, is always to think about ways in which you can support democratic ways of caring. Because the more democratic we make our practices, all of our practices, from our families to our institutions, to the hospital, to our organizations, the more we all practice caring in a democratic way, the better we will get at it, and the more we will be able to apply it in all of the situations that are important. Next slide. Meanwhile, let me just mention what's happened in Alabama. The American Civil Liberties Union became involved, and by now 2 preliminary injunctions have been issued to stop the state of Alabama from instituting this policy. The article in the New York Times and another article that was published in a local paper in Alabama makes clear, though, that the harm has perhaps already been done because these birthing centers simply can't function without patients. And since they've lost patients already, they may not be able to reestablish themselves and go on working. But at the moment, this is on hold. Now, by the way, Annie Benzel's work on how poor health outcomes for midwives, you might want to look at those essays as well, and they're here. Thank you very much.
Thank you so much, Joan. We deeply appreciate all of those thought-provoking questions that you left us with as well. Just as a reminder to everyone, we are going to have Dr. Chimienti come up now to do her portion, but if you've got questions or wonderings in regards to what Dr. Tronto just shared with us, please don't hesitate to put those in the chat, and we'll make sure that we save those, and then we'll also do a call again. So as I mentioned, next, I would like to introduce Dr. Sonia Chimienti, and she is going to help us explore the relevance of caring for medical education and practice specifically, walking us through a case study to show how the elements of caring character and practical wisdom can be applied to complex real-life issues in the field. Sonia, the floor is yours.
First, I'm delighted to join you all today, and I'd like to start by thanking the KNN leadership for inviting me to share a few thoughts and perspectives, asking me to apply the concepts of the KNN framework and the concepts that Dr. Tronto has shared with you to the work that we do in medical education and to a hypothetical scenario. I'd also like to extend my thanks to the extraordinary educators and students who have really shaped a lot of the ideas that I'll share today. We are truly in a privileged responsibility in what we do, and I just want to reflect back those words that Dr. Tronto used in her presentation. I have a few disclaimers before I begin. First, these are thoughts and ideas that I will share that have been formed from 22 years of being entrusted with guiding the careers of learners at different levels. I served as a GME Fellowship Program Director for a number of years, then Dean of Students, and then Vice Provost for Student Life. And throughout that time, I have seen many learners struggle through challenges, thinking about how they have navigated that. I've reflected back, and I believe that my strong belief in caring as being foundational, a foundational aspect of their formative growth and the development, that has led to their successfully navigating some of those challenges. I also have to acknowledge that I don't have scientific or randomized data for what I'll share with you today. These truly are perspectives, but what I do have is qualitative outcomes. Many of the scenarios that have guided the principles I'm sharing today really result from my continued follow-up with these students and the way that they have really flourished in the latter parts of their careers. So with that, I will jump in. So this is the agenda of what I'll go over today. I will make the case for linking caring and our work in professionalism and professional development in medical education. I'll talk a little bit first about why we should discuss caring in medical education. Why is that important in the learning environment? I will set us up with a challenging real life-ish scenario. It's a little bit made up from multiple different scenarios pulled together. And then I'll walk us through the way I think we try to practically apply care ethics and leading with caring to these different scenarios. And I'll try to connect a few dots from Dr. Tronto's presentation, responsibility, talking about power and the hierarchies, and then also making sure that we are tying in the KNN framework. So why discuss caring in relation to professionalism, in particular in medical education? We've heard a lot in Dr. Tronto's presentation about our work as healers. What we do is grounded in caring. And even though I'm talking about medical education, because that's the domain in which I work, I also invite you, as I talk about this today, to think about healing and health professions education a little bit more broadly, whether graduate medical education, UME, nursing, or allied health professions. This is what we do. So why must we deliberately and intentionally explore bringing caring into medical education? Well, there's a quick PubMed search that I show here that I just ran yesterday. Using the search terms medical education and burnout, you can see that there's been a significant increase really in the past 5 to 7 years of papers exploring burnout and the challenges that we are experiencing in medical education. I think many of us here who work in medical education would very quickly realize and agree that medical education, that journey that students go through, can change us in profound ways. Burnout, cynicism, decreased empathy, depression, and all of their impact on learning, very well demonstrated in the literature. So I won't go into that today, but I will say that I believe that if we don't attend to the issues of how medical education impacts learners, we do have a crisis in terms of how those learners are experiencing the world that they are learning in and that they will practice in. I don't want to go into a lot of literature, but I have 2 slides here of recent studies that sort of captured me recently, which illustrate some of the more recent work in this area. The first one that you'll see there, evaluating the relationship between medical students' empathy, their mental health, and their burnout. The other highlights that this is impacting the literature, not just in medical education, this is cardiac literature, looking at the training environment, the culture in which graduate students train, and how that impacts their mental well-being. The third here is a pilot randomized clinical trial looking at compassion cultivation training to reduce the psychological distress of medical students in the learning environment. And this was a pilot study showing that that can enhance compassion skills. So that compassion cultivation training may be one way to start thinking about how we can improve outcomes and decrease the loss of decrease the loss of empathy and the burnout that our learners experience. And then the final 2 here, a longitudinal study looking at the impact of the learning environment on career regret. We don't want to graduate students who've changed so fundamentally that they regret what they have chosen as their career. And then finally, there are studies looking at stoicism, stoic principles, mindfulness, and how that may help to maintain medical student empathy and resilience in the face of the changing learning environment. I'd like to talk now just a little bit, and again, there are plenty of articles in this area. Those are just a few that I found to be particularly interesting. But I'd like to talk a little bit about caring relative to medical education, and then specifically link the importance of caring to our concerns about professionalism and professional development in the learning environment. And I believe that this is critical as well for the formative growth of our students. So the KNN framework, Kimara showed this to you a little bit earlier, and I'd like to zero in on particularly one aspect of it, the caring aspect. So the definition that the KNN has of caring is listed here. Caring is a blend of practices, dispositions, and motivations, including attentiveness, responsibility, there's that really responsive word again, competency, responsiveness, and engagement citizenship, all aimed at ensuring that individuals and populations grow, develop, and flourish as best as they can. So thinking about that definition, thinking about caring in medical education, how do we use that as a framework to help support students through professionalism challenges in medical education? What is our responsibility? And reflecting back to Dr. Tronto, to whom are we responsible in this way? So this is a complex and hypothetical scenario. It is a composite of real issues. This is not one story from one institution. I'd like to be very clear that this is a hypothetical scenario that I have culled from multiple scenarios that are real, experienced at multiple institutions. There have been a couple of aspects that I have included that are fictional. So in this scenario, it is early 2021. And a medical school class has begun their first year, their preclinical education, in the midst of pretty significant situational change, devastating impact in our society, the ongoing COVID-19 pandemic. And at that time, a student comes forward to the Dean of Students to share that confidential test preparation information is being shared across the class. An answer key to a clinically based summative exam, an OSCE, has been distributed. And the student comes concerned, sharing that they're not sure how many students received the answer key and that they did not know what it was when they initially received it. So they did open it. They thought it represented a study guide, but after opening it, they quickly realized that it was an answer key from the prior year's exam, and they discarded the resource. Now, this student recognized that something was wrong, and they are concerned because they feel that this represents academic dishonesty. They are also concerned because of the inequity and imbalance, the sharing of this information, not with the entire class, but with some. Not only is it cheating, but they have an advantage if they have received it over those who did not receive it. They are also not sure that the person distributing the answer key is aware of the severity of what has occurred, and the student has significant moral distress over bringing this forward. They're not only concerned about the individual who is sharing the information and the class as a whole, they believe that approximately 50% of the class received the information. So what is occurring here? This is a challenge that may resonate with many of us in medical education. It's likely that at some point in our journeys, in our work, that we have encountered challenges of academic dishonesty. So there are obvious and important issues that may come to mind as you hear me relate this scenario. Certainly the concerns of academic dishonesty in the medical profession is of grave concern. This is a violation of the fundamental tenets of our profession. There are also issues, as the student brought forward, of equity. If the grades of students are impacted in ways that create inequity, are there some that might benefit? And there's also accountability, and we'll talk a little bit about that. There are some not so obvious issues as well. So I think probably as I was reading the scenario, many of you may have very quickly zeroed in on these issues that came to mind. But there may be other issues underlying, and this is where the caring piece, the framework, and the concepts that Dr. Tronto shared really do come to play. Do we know that anyone actually used this information? Who is accountable in this scenario? A simple answer is the person who distributed it. What about those who may have received it and used it? What about faculty for potentially reusing exams rather than writing new questions? I realize that's a bit of a challenging statement, but there's a lot going on here that once we start to dive into this and take responsibility for understanding the scenario, that we need to unpack. And so what challenges might also be underlying this broad sharing of information? Does the student know that this is academic dishonesty? What was going on that made the student feel that this was okay to share? So I'm going to do a little poll. I'm going to show you a QR code in a moment on the next slide, and I'm going to ask you to share your perspective on what you might do next. And first of all, there's no right answer here, but I would submit that over the course of my career and having conversations with faculty, I have had each one of these responses in challenging scenarios. So these are what I share with you that faculty may have mentioned to me either in committee meetings or in conversations. You might immediately convene an honor board to include all students who were copied on the email, and that information is available. You might request the name of the student distributing the material and just bring that student to an honor board. You might request the name of the student distributing the material, meet with them, and then have a meeting with those who received it to discuss what had happened. You might sit down and meet with all students in the class to discuss the concerns and our accountability for academic integrity and use this as an opportunity for formative growth. Or you may do none of the above or something else. So you can take a moment, and I think that should be active. You can scan the QR code. So we are going to present. And we'll see how the answers come in. All right. So we have a majority of respondents saying that they would use this as a formative opportunity to meet with students in the class, to discuss the concerns and our accountability for academic integrity, and share a plan as to how the institution, those in leadership, will address the issue in a way that applies to all students. And then about a third of respondents saying that they might request the name of the student distributing the material, meet with them, and then meet with those who'd received it, just specifically that group, to discuss the issue. Okay. Over here. All right. So what I'm hoping, before I go to this, what I'm hoping is that as you were thinking through this scenario, some of the concepts that Dr. Tronto talked about, some of what we discussed was really maybe playing a role in how you are approaching or thinking about that scenario. This is an issue of professionalism, which, again, I suggest that probably many of us have encountered this in some way, shape, or form. I'd like to take a moment to read a paragraph by Dr. Catherine Lucy. This is from one of the AOA monographs from 2015. It was a wonderful monograph focusing on professionalism in medical education. And I'd like to call your attention to some of the things she says here, which really resonate with me as an educator. Like medical errors, professionalism lapses are more common than we might think. They occur in predictable circumstances when individuals are stressed, the situations are highly charged, and controversy is present. As is the case with medical errors, those whom we otherwise consider to be good physicians commit occasional professionalism lapses. Thus, professionalism must result from a temporary mismatch between the individual's knowledge, judgment, or skill and the complexity of the situation in which he finds himself. And finally, the systems in which we care for patients and educate learners may either help us sustain our professional values or set us up for failure. In other parts of this monograph, which is really excellent, the point is made that learning the profession, professional expectations, is really a continuum. If we all knew exactly all of the rules and we knew how to apply them in challenging or stressful circumstances, we may never need to teach this. And so part of our role as educators is to serve as guides, to provide that formative feedback and to help guide people with caring at the center of what they do. And again, I'd like to reflect back to Dr. Tronto's statement that care ethics is valuable for its broadly different approach as a relational rather than a static ethic, and responsibility is a key concern. Dr. Tronto draws a distinction between obligation and responsibility, which I really love, and I think that can help us as we approach difficult situations with our learners. And so she mentioned that responsibility grows out of response and is interactive and is subject to change. And so what constitutes a proper form of responsibility, and here's where I would also bring together practical wisdom, really requires ongoing negotiation, understanding, and the application of important principles depending on a particular setting. So I would argue that medical education involves a privileged responsibility rather than an obligation, linking back to Dr. Tronto's concepts. In a medical education, to foster the growth and trust and to impact well-being, we must see our roles as one of responsibility to guide and educate during these critical times. We must, of course, adhere to the expectations of the profession. I don't want to in any way, shape, or form suggest that that's not the case. But that deeper understanding, that responsibility to learn what is happening, to assess the complexity of the challenges, to understand deeply what happened, and then to apply caring to our guidance and growth of our students can lead to better outcomes. So in this particular scenario, how do caring and responsibility enter the equation? Well, I'd like to mention, again, reflecting back to Dr. Tronto, in this scenario, there are multiple people who we as educational leaders must care for. We definitely must care for the students who are trusting us to educate them. We absolutely must hold in our caring our future patients and our society who trust us in our roles as educators to guide our students. And we must care for our educational teams, those who are supporting the students. They're trusting us to do the right thing and to uphold the rules and to provide those guideposts in a way that does honor the needs and the intentions of the profession. So can caring inform our approach in this scenario? And how do we use our position of relative power, which we talked about earlier, to center our response on caring? So again, I believe that it is our responsibility to probe, to understand, and to use caring and practical wisdom to address these issues. And again, I'd like to very much reiterate that academic integrity is critically important in our profession. By no means do I suggest that it shouldn't be also at the center, but how we approach these challenges can help to either shape the growth of our students and impact their growth in a positive way, or it can derail them. Caring for our educational teams, I just want to highlight a couple of the things that we that I try to remember in these types of challenging situations. So what are the perspectives of our educators? Well, in these particular scenarios, they are concerned about the sharing of academic information without permission, academic integrity, a disrespect for the educational process, a lack of integrity regarding learning the material that is critical to becoming a competent physician, and the increased work of the educator to create new exam material in short order if that sharing of information leads to not being able to use the exam. Our patients and communities also have perspectives that we need to consider, and we need to care for them. They trust, Dr. Tronto mentioned this, they trust in the educational systems that we're creating, that we are providing students with the opportunity to learn, to become competent in medical knowledge, communication, professionalism, and multiple other domains. And they're trusting that we are helping students to develop and maintain the values and ethics of the profession. But our students who are there trusting us to guide their educational experience, I think many of us would think about our students who matriculated and remember that they come to us, they come to medicine with dreams of making impactful changes in society. This system in which we train them has always been challenging, and I believe it's becoming increasingly challenging. The explosion of information, the science, the knowledge, everything they need to learn, the competing demands that they have to navigate as they work forward in their careers, all of this is causing additional stress. I offer this not as an excuse, but that privileged responsibility as educators to understand how we can guide students through that. And in this particular scenario I shared with you, there were multiple situational stressors, and we live in a very complex world where emotional distress, where moral distress can impact our learners on a daily basis. World health, pandemic, political strife, challenges nationally and globally. They are not immune to this, and they are trying to learn to be healers in the midst of a very complex world. So they trust that we will be aware of these challenges and that we will create a caring learning environment that supports their professional growth and development. So in closing and coming back to the KNN definition of caring, a blend of practices, dispositions, and motivations. They require us to be attentive, to have that privileged responsibility, competency, responsiveness, and engagement to ensure that our individuals and populations can grow, develop, and flourish as best as they can. So again, be attentive, understand what has happened in this scenario. We must lead with responsibility. We must apply competency to the situation. We must be responsive, and we must engage deeply. And all of this does take time and is more complex than simply applying the rules. But I think this leads to better outcome as we care for our patients, our society, our educators, and our students. So there are two potential sort of broad outcomes for this scenario. Certainly can activate an honor board right away, either for an individual or a group. And certainly that addresses the caring that we need to attend for our patients, our society, and our educators. But could we also, and I believe that some of you suggested this in the poll, could we use this challenging incident as a learning opportunity? Something went wrong. Good people made poor choices. How can we engage with our students in formative solutions? And I'll say in this particular scenario, the solution that we did was we met with the entire class. It wasn't about who was sharing the information or who was looking at it, but we used this time to meet with the entire class and to let them know that the exam would stand, but it would only count as a pass for all of our learners. So whether you received honors, high honors, or anything else, the entire class was given a pass if they passed on this exam, and then a new exam was going to be made the next year. And we talked about why this was not okay. So we use this as constructive dialogue to highlight issues and consequences. And in this particular scenario, we felt that our caring centered on all of the stakeholders whom we support. Thank you.
Thank you again, Sonia, for that powerful example in challenging our thinking and how to directly apply Joan's concepts and the KNN's framework. At this time, we would like to open it up for questions that we may have, and again, invite you to submit those via chat. I have gotten some sent to me personally and directly, and so I'd like to start there. Much of them really leaning into this concept of complexity, which I couldn't help, Joan, see how you talked about that, and then Sonia's example really highlighted sort of the complexity as well as the sense of responsibility versus obligation. So this question really, I'd love to hear from both of you. Joan, perhaps you could start, and Sonia, you could follow. But the question is, how could we as individuals or agents within these complex organizations encourage those within to consider purpose, power, and pluralism in how they're allocating responsibility, especially really given that point that you made, Joan, that oftentimes institutions may find that they benefit from lines of responsibility being disguised or ambiguous.
This is such a difficult question to answer because, well, here's my somewhat optimistic answer. Academic institutions, and I think for the most part, medical institutions, really have a clear sense of purpose. And as a result, there is less hierarchy. There's less do it because I said so. And there is more of a sense of a communal activity. So all of us have voice in institutions. Some of us have louder voices or stronger voices or more powerful voices, but all of us have voice. And if we use our voices to make sure that we keep focused on the right things, then we can perhaps keep focused on the right things. When people aren't focused on the right things, we need to speak out. And we also need to make it possible for those who are in positions that are less powerful to speak out. So we need to somehow be able to use whatever situational power we have to make it possible for others also to speak out. And we need to call out when responsibility isn't being allocated properly and isn't being taken up. So in this case, to simply have convened an honor board would have been really, I think somebody might have said, this is not the responsible way for us to respond. If half the kids in the class are doing something, it's not just one person who's got a problem. It's we've got a problem. Yeah.
Thank you. Sonia?
Yeah, I just want to build on that last point. I think that that's kind of the aha moment and the insightful statement there, in addition to what we've talked about, is we recruit nurses, physicians, dental professionals, allied health professionals, because they are seeking to do something good for people. They're seeking to help. And when there is something of that magnitude that happens, I think that the privileged responsibility, the power that we do have, whether you like that word or that situation or not, is to take a step back and say, what do we understand from this situation? What has happened? That's the practical wisdom. We might have a very different approach that's still centered on caring, but a very different approach if it's one versus half the class that is doing something. So I think that's what society, our educators, and our students are all entrusting us with, is how do we respond to this in a way that gets us to better, while also ensuring that the important principles are being followed and that the integrity is there.
So we saw in, Sonia, in your hypothetical example in the poll that we took, we didn't see anyone choose A or B, as Joan was suggesting, which perhaps that's a bit of the audience that we have that has joined us. I'm curious, there was some conversation, myself included, about sort of a C then D kind of approach, and would love to hear, thoughts from both of you on what does it look like to care for the whole while also caring for the individuals, and responsibility there between individual and whole. Just love to hear your thoughts on that.
Yeah, if I can dive into that. So part of the scenario that was real was the magnitude and the sharing of information for a particular exam. And there was, when it was first brought forward to me, there were individuals involved who asked the question, well, if school email was used, can't we just find out who received it, who has it, who opened it, and then meet with them? And again, I think taking a step back, I feel like we also have the responsibility to model behavior that is ethical in the highest way. And at the time, I didn't feel that was the right call. The answer is yes, we can do that, but we're not going to do that. And that was why we went right to D, because we didn't want to dive into emails, even if it's institutional email. But we wanted to use this as an opportunity to get to the why, and to get to the why it is not okay. And both of those were really important. But I think the accountability of the individuals, there may be some faculty that are left with it, well, you didn't really hold the individuals accountable who had been sharing this. And I think I would offer that the benefit for the approach that we took outweighed the risk of individuals not being held accountable, because the class was held accountable. And, that is part of what we decided was the right call in that situation.
Joan, is there anything further you'd like to add there?
I want to stress one thing that Sonia said I think is also important, and that is this issue of disrespect for the educational process. And one of the things that doesn't happen is students don't really see how much work has gone on, say, in preparing an exam, and don't understand that that's a lot. you're asking people to do a lot when you ask them to rewrite the exam because you missed it or something. And I think if students had a greater appreciation of what it is that is actually going on among their faculty, they might also, again, then they would see themselves kind of as partners in this process rather than as the ones being victimized by these mean professors who keep asking them these tricky questions. Yeah.
I think you, Joan, absolutely. And that's the real growth opportunity here that would be missed by moving right to accountability and to an honor board. Because when you have that dialogue, you have the ability to share. These are educators who are working so hard, who are trying to balance either research or clinical obligations with teaching. That appreciation of what goes into these exams, how much work that is, may not be apparent. So, and it's our responsibility in our positions to really balance the caring, again, for everyone, including that team or those people who need to go back then and recreate a new exam. So that's where the aha moment happens. It's not just about me in that moment, but there are many others involved here that could be hurt.
Thank you. One of the points, Joan, that you really stressed, particularly near the end, was this sense of democratic caring and leaning into what democratic caring is. And if I could tie that into a question that we got really about the faculty and their reaction to the cheating scenario. You know, this person comments, it's likely that the faculty did or would have been divided about how to respond. And so what kind of discussion or dialogue would you imagine or would you see? And how does that idea of all of the different people that you're really responsible for or are involved in this scenario, how does that contribute to the sense of a democratic approach to caring?
Sonia, was it in fact the case that the faculty were divided about how to respond? Or if you imagined a faculty, we're not talking about an actual event, but
yeah, so I'm piecing together a few different things. So I'll share that sometimes I do get different opinions from faculty when certain challenges occur, and you know, if a student is repeatedly late to a class, or you know, various different professionalism issues as a whole, oftentimes there are different opinions from faculty on how to proceed. So again, this was a composite of lots of different ideas, but
yeah. My answer to this is that, of course, there's going to be disagreement, and that's part of a democratic process. Is there's disagreement. So, you know, if some people are they less caring because they want immediately to go to an honor board? No, not necessarily, but they might be. And it might be that talking about them in this context would be persuasive. But if it isn't, then you just, you know, follow democratic rules that are set in that particular faculty about how to proceed.
Sonia, I'm wondering if you've had situations, whether it's this one or others, where you really needed to deal with a faculty response to a decision you've made in regard to student actions and how you've navigated sort of the different perspectives that arise.
yeah, we live in a complex society where needs and responsibilities are different, and so people will bring different perspectives to the table when there are challenges. You know, even today I received an email from a faculty member asking about a certain decision and sharing that they were a little bit frustrated with it. This is where, and I'll connect with some other work that the KNN is doing right now, bridging conversations. We, since the pandemic, I think, live in an increasingly disconnected world where being able to sit down across the table, bring people together and work through scenarios becomes a little bit more challenging. It's almost easier sometimes to default to Zoom. I guess my answer to your question, Kimara, is When there's a challenge, when there's somebody that has a disagreement, my default is to try to bring people together in person across the table to talk, to share. I think the being able to pick up nuances in conversation when you're in person really helps. I mean, obviously we can't do that all the time, but dialogue. I think it's rare that I've ever said, I don't think I've ever said, well, that's just the way it's going to be. That doesn't sound like something I would ever say. I think trying not to get to consensus, but to understanding. I guess that's the word I'll use. Trying to at least have people walk away from a conversation, even if they don't agree, they understand.
Thank you. I think that's really powerful. And it reminds me of, you know, to some degree, the relational ethics piece that you were bringing up, Joan, that seems to loom large in this scenario and this thought process. And just that thought of how are we moving towards relationship and opportunities to understand, and then that idea of making sure that all voices are heard in a scenario, and that we are using our positions of power and influence to make sure that voices that may not naturally be in that space, and depending on the scenario, that could be a student voice. I've certainly heard it can be faculty voices at times, depending on the situation, and understanding that. So we are very grateful to our speakers and to our participants. We are at our time, so I want to be really mindful of that. For your time, for your perspectives today, we want to extend our thanks to the Kern Family Foundation, whose support makes all of this possible. We really look at today's session as just the start of the dialogue on this important topic, and we invite you to continue to engage with us in this important work. And there are so many different ways that you can do that. One of them is becoming a member of this movement. Members are a forward-thinking group of individuals and organizations that are really committed to advancing flourishing and applying the framework in their settings. And we are just looking at the same time, right? They have this ability to gain support from the broader network, access to resources, expertise, and national opportunities to be able to raise the work. In fact, as part of today's session, members are invited to join us in just a moment for some additional time with our expert speakers, and Joe is going to be part of that. So Sonia, we won't miss Joe's question because he's coming into that with us. We're going to be opening that breakout room shortly, so please, members, do stay on the line, and we would love to have you join us. To everyone else, thank you again for attending, and we hope to see you for our next session, which is February 26th, where Dr. Peggy Plews-Ogan will present on practical wisdom and how we cultivate it within medicine. Have a wonderful evening, everyone.